Nope.
This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
ENT surgeon in New York and New Jersey with ENT and Allergy Associates.
And I'm Dr. Marina Kurian. I'm a general surgeon, and I do weight loss surgery as well in New York City.
This week, we're going viral for our 24th show and a little bacterial. Our guests are infectious disease doctor and Twitterati from Mayo Clinic, Dr. Aditya Shah, and virologist from St. Jude's and the WHO, Dr. Richard Webby.
Right. So the WHO, as everyone knows, World Health Organization. But I did think when we were listening to the intro, Doctor Who. We can't wait until Dr. Webby comes on. It's going to be great. But you guys know before we start the show, we're going to do a quick discussion. But this show this week is going to be so fantastic, talking about COVID with two great experts. And so we're going to keep it brief, but we will just give you some of the highlights of what's happening in the U.S. And right now, we unfortunately have hit over 250,000 deaths directly attributable to COVID-19 this past week, and we are losing over 1,500 per day to this disease, which is officially a little less than one death per second. And that's super, super unfortunate.
Marina, this week, just to pass the time, I guess, my family and I went over to a nearby 9/11 memorial where all 3,000 names are carved into the wall. And it was so sad and heartbreaking then. And what's really sad and heartbreaking is we're losing a 9/11 worth of people in the United States every 1.5 to 2 days. And this is something that we really can prevent. And as we're going to talk with our guests, we can treat. It's very exciting in medicine that President-elect Biden has named his COVID-19 task force. And they really include leaders from various aspects of health and public health.
Yeah, and I think that's fantastic, right? There's a former Food and Drug Administration commissioner. The Dr. Marcela Nunez-Smith is the co-chair, Yale Associate Dean for Health Equity Research, and also Vivek Murthy. They're leading it is a former Surgeon General, and he's also one of the co-chairs. So it's sort of like a triumvirate, if you will. But then you look, and you see some other familiar names that are there, like Atul Gawande, who has that great sort of health initiative with one of the major players. I can't remember if it's Google or if it's Amazon that he's working with. So they've already had their first briefing, and it's going to be, I think, very good. Actually, the current coronavirus task force just had a briefing, right? First since July.
Yeah, they gave us one since July. And really, I think the CDC, the FDA, the coronavirus task force, everyone is encouraging caution. There's a current enormous rise in cases, urban, suburban, rural. And we find that in the beginning, most transmissions were happening in big places like food processing plants or nursing home facilities with a lot of people. And we're certainly seeing that kind of transmission, but we're seeing more transmission happening in small family gatherings. And speaking of family gatherings.
Right. So where Thanksgiving's coming up, I've got my bubble super small. But there's this great piece on epidemiologists, so people who are tracking a disease and how they're going to spend their holiday season for Thanksgiving and the winter holidays. And it's saying that the majority of them, based on their interpretation of the data, are going to spend it only with their household. And so very few are going to spend it with another family, because when you bring another family in, it's another bubble. And then, of course, there's some that are like, we're not even doing dinner. That seems like kind of like
like you gotta eat, right? Not for nothing.
If there's such a thing, but
Well, I usually host 25 or 30 people, or maybe 100, I don't know. And it's really down to just the people who live in my house now. And that's okay, because I'd rather be safe this Thanksgiving, be safe this holiday season, and celebrate next year. But we are live on Facebook, YouTube, and Twitter. Please like and tag your friends who would be interested, who is not interested, I don't know, in listening to experts talk about COVID. And please share. We are so excited to welcome our guests, Dr. Aditya Shah, who is infectious disease and tweets as at ID.Adi. And Dr. Richard Webby, who is a virologist and infectious disease faculty at St. Jude's Research Hospital and director of the World Health Organization Collaborating Center for Studies on the Ecology of Influenza in Animals and Birds. And we're very excited to welcome you both to our show.
Yeah, thank you so much for joining us. Well, we're going to start off with questions because we have so many. And those of you who are watching, again, if you have questions for our experts, definitely, just tweet them out or on Facebook, write them in, and we will certainly get to those questions as well. Adi, we're going to start with you. You're in Minnesota. I just talked to one of my girlfriends who's a doc out there as well. And she's like, it's bad out here. So how bad actually is it? And what are you finding? And are you, we see that you're on call.
Yes.
You're at the hospital.
Yes.
But are you having to lead your own team and what's your ICU capacity reaching? I think if you can just describe what's happening, you're in a major city, but what's happening outside in Minnesota in some of the more rural counties where they may not have ICU capacity.
Sure. So we are the biggest tertiary hospital here in Minnesota, and we're getting a lot of transfers from surrounding small towns and cities to our ICUs and our hospitals. We've never seen numbers as high as since the pandemic had started. We are seeing anywhere between 300 to 500 new diagnoses in our county, which is Olmsted County, almost every day. across the Midwest, a lot of healthcare providers in the Mayo health system have also been affected, mostly getting infected from the community. And then, because of being infected or exposed, a lot of people are on isolation or quarantine. That is then impacting staffing in the hospital, especially nursing staffing. And that therein lies the problem. And that's why we are seeing a lot of cases now. Without going into specifics of the numbers, we are getting at capacity in our ICUs and also on the floors. And we are seeing a lot of patients of all age groups, all races, all backgrounds coming into the hospital getting pretty sick. The only difference is that now we are more used to managing these patients. Initially, infectious disease used to be involved in every COVID case in some capacity, but now, because of the sheer number of cases, we've come up with algorithms so that other specialties like pulmonary critical care, emergency medicine, hospital medicine can also take care of their patients, with infectious disease only being involved in like consultation capacity. So we are seeing a lot of patients higher than we've ever seen in the pandemic. Exhaustion is definitely creeping in. I've been on service, it feels like forever. I'm going to be on COVID again in a couple of weeks, and we're expecting high numbers then from what may or may not happen this Thanksgiving. So the governor thankfully has put out another restriction last Friday. And so restaurants and gyms and all kinds of places where people can congregate have been prevented from being open, which is a good call. And we are going to do that for 4 weeks and then take it from there. So yes, the upper Midwest, not just Minnesota, but other states in the upper Midwest also are seeing a lot of cases. And that's why we are urging the community to help us out as we try to deal with this.
Thank you. I think, our hearts go out. Out here in New York, New Jersey, we saw that first wave and we found it awful. And this third wave is about 3 or 4 times that size. And I know it's cold up there in Minnesota. Richard, you're down in Memphis, which, is a city I really, really long to visit. But it's warmer down there. What are you seeing in your community, in the hospital? What's going on down in Tennessee?
Yeah, well, good morning, Sujana. I would suggest you don't come right now.
Thank you, I won't.
Yeah, we're in pretty much the same situation. So locally, both in Memphis, and actually I live in North Mississippi, which is a 25-minute sort of jaunt south of Memphis. It's the same in both those communities. We're seeing spikes in cases. Although I'm not directly involved in the treatment of these patients, from what I understand, the ICU beds in Memphis are right at capacity as well. So no, it's certainly no respite down here, even with the slightly warmer weather. So things are definitely very hot.
And what's very hot, really? What's happening with bars and restaurants and schools and universities by you, Richard?
Yeah, so in Shelby County, which is the county which Memphis sits in, they've just on Friday, they've released some further restrictions, so limiting the hours that restaurants and bars can service. And again, bars, I think there was a Facebook post. I was looking at my wife's account today, and they said it used to be you can smoke in bars, now you can't even drink in one. It's pretty much a case now. So again, you have to be, if you're in a bar in the county, you have to be eating. So again, they've started to try to do things to put the brakes on a little. I guess we'll see in a couple of weeks as to how successful that's really been.
That's really going to be critical, right? Watching what's happening in the next 2 weeks, because we're not going to see a spike, the Monday after Thanksgiving. It'll be 2 weeks later. So, Richard, can we go through a little bit about the different viruses? Because just as a virologist and looking at SARS, and there were 2 other significant coronaviruses before, but there are also coronaviruses that are like a cold. And I've heard it said, and I think you said it actually, that perhaps people got really sick from these other coronaviruses that present as a mild cold now. But but we've had them circulating in our communities for so long that you just get a cold instead of having this horrible illness, what we're calling COVID-19.
Yeah, so that's right, Marina. So if you look at this group of viruses called the coronaviruses, so it's their Thanksgiving family. There are a number of different viruses in that family, and there are actually 4 of them. The sort of common cold coronaviruses that we probably all get as young kids, and these are cause the sniffles, the winter sniffles, the feeling unwell for a few days, but no major impact. And when those, if we go back in time further up their family trees, once upon a time they were animal viruses. So just like this SARS-CoV-2, COVID, sort of coronavirus, whatever you want to call it, the one we're dealing with now, these common cold viruses all started their life as animal viruses. We think probably in bats, but we don't really know. And they transitioned through perhaps another animal host and found their way into humans. And if we think of viruses more generally in terms of the disease they cause, that's really a combination of 2 different factors. One, how much capacity that virus has to cause disease itself, but also how much immunity our bodies have towards it. And so there's the sort of the Thanksgiving phylogenetic tree of the coronaviruses. And so what probably happened when those coronaviruses, those common colds first came over, we don't know when that was, many years ago, when there wasn't a lot of immunity in the population. Those viruses could very well have caused some COVID-like disease, but as the population built up immunity to these things, that's when it settled down to more of a common cold type pattern. And that's at least what we're hoping is going to happen with this virus. When we get enough population immunity, and there are, again, 2 ways to get that. One is through infection, and the other, I think we'll talk about later, it's through vaccination. When we get that population immunity built up, I think there's hope that COVID-19 will drop down more into this seasonal cold type pattern. So that's kind of the hope.
That would be fantastic, because I think you have pointed out in your writing and your lectures that, we see a lot of flu, we see a lot of cold, and we only see really susceptible people succumbing, whereas right now we're seeing people who are healthy succumbing to COVID. Adi, maybe you can talk to us a bit. One of your passions is having people not take antibiotics unnecessarily. So I think, stepping back a little bit, can you just talk to us briefly about the difference between bacteria and viruses, and then talk about your passion of antibiotic stewardship, which is the guidance that infectious disease doctors give us so we don't abuse antibiotics, and why that's important.
Sure. So the basic difference between the bacteria and viruses is genetic, in the sense that a virus can essentially integrate with your own lymphocytes or in your own cells or your own immune system, or essentially your own body's genetic material, and start essentially causing a cascade of replication and then inflammation. Whereas bacteria cannot survive with your own DNA, and it needs its own genetic mechanism to essentially survive. Now, the basic issue with antimicrobial stewardship or antibiotic usage in general is that every year we see close to about 30 to 35,000 cases of antibiotic resistance related deaths, and about 2 million cases of antimicrobial resistant bacteria through the US. In the initial part of this pandemic, what started to happen with regards to COVID is that because it looked very similar to your community-acquired pneumonia, i.e. with infiltrates in your chest X-ray, fever, cough, shortness of breath, essentially something so similar to a community-acquired pneumonia, a lot of patients right off the bat started getting ceftriaxone, azithromycin, everybody's favorite combination, vancomycin, if they were more sick, to cover a bacterial co-infection. But thankfully, a lot of research and quick research has come out to say that the chance of bacterial co-infection infection with the viral infection is very low, almost sometimes even lesser than 4 to 5% of cases. So we've done a lot of efforts to limit antimicrobial use in these patients with COVID infections, because as you know, and as your audience might also know, is that what we do to patients with antimicrobial exposure today can essentially rear its ugly head in the future with issues with drug resistance and side effects and C. diff and all other aspects of it. So though COVID is the pandemic which is in our faces right now, antimicrobial and drug resistance is a slow epidemic which is going on in the background in a very silent fashion, killing about 35,000 Americans every year, and about 2 to 3 million cases every year, leading to significant mortality, morbidity, and cost on the healthcare system. And then essentially the vicious cycle of more antibiotic use and more resistance and such. So we've come up. Sorry, go ahead.
I have a question for you. That, in the beginning in New York, when this was happening, there was an antibiotic cocktail that was given to a lot of people. And predominantly is because they felt that they had a lot of pneumonia and that there was a bacterial superinfection. Is
Sure.
that not what you guys are seeing now in Minnesota?
Not just in Minnesota, in the country and in the world, cases are coming up, and the bacterial co-infection that you mentioned is almost as low as 4 to 5%. Now, as you know, if somebody is admitted to the ICU with a severe COVID infection and they're in the ICU for 5-6 days intubated, then yes, these patients do become at a risk for having stuff like tracheitis or ventilator-associated pneumonias and such. But the whole concept of right off the bat antimicrobial use is not proven to be needed in the studies that have been done. Now, if somebody, again, there's obviously caveats to this. If somebody is admitted to with COVID in the hospital, gets discharged, gets worse 7 days later, then you have to think about the secondary bacterial infection after a viral infection. But the right off the bat antimicrobials are not needed, because studies are showing that only about 4 to 5% of cases present as bacterial co-infection, but we are just seeing everybody get started on antibiotics, and that is not needed.
So I think that's an amazing statistic, right? If only 4 or 5% really have bacterial issues, what are we treating with antibiotics? And one of the things you do, Adi, which I really admire, and Marina and I really admire, is your Twitter feed shows funny videos and you tie it in to some of your medical passions.
Yes.
This one was crazy. Can you explain this one to us?
Yeah, so the whole concept, I get peeved. My pet peeve is incorrect usage of terms, like, patients going Cersei, so we started big gun antibiotics. And the whole concept of big gun antibiotics means that they're essentially trying to use antibiotics which are broad range, which will take care of whatever infection that you may or may not have. So I just came across this funny video, and I'm like, this is exactly what happens when you treat somebody who perhaps needs no antibiotics or just an oral antibiotic like Augmentin with your big gun antibiotics called Vanc and Meropenem, which then causes havoc in your normal beneficial gut flora and then leads you to have issues with C. diff or drug resistance in the future. So this kid blowing this firecracker just made the point for me. And I do that. Yeah, I have a weird sense of humor. Sorry.
That was really funny. And both, of course, Suju and I, we have kids, and we're like, why was the young lad with no shirt holding like a rocket launcher? Like, this seems wrong. And I'll just say quickly about antibiotics, and ENT docs get this a lot more. But I was sick. I had like yellow, green mucus, coughing, hacking, all this stuff. And I happened to bump into another one of our good friends, Dr. Kumra, Sujana. I cheated on you with another ENT. She at the OR desk. So I was like, dude, I need antibiotics. What should I take? And she's like, you don't need antibiotics. Go get Mucinex and stop this nonsense. And I was like, it's green. It's like bad. And she's like, no, go get Mucinex. So what happened is I was a convert, because I did get better without any antibiotics. And I was such a convert that my friends who come to me and they're like, I need antibiotics, I have a cold. I'm like,
You need antibiotics if you have fever, or if your symptoms last more than 10 days, or if you have frank purulent pus coming out of your nose, which is very rare. But everybody gets Augmentin or Z-Pak or Levaquin, and then a couple of weeks later they're presenting with C. diff. So that's bad.
One of the things we say is, well, you can take a Z-Pak for 5 days and you'll get better in a week, or you can just wait and you'll get better in 7 days.
Exactly. Exactly. We call these emotional support antibiotics. It just makes everybody feel better.
That we have emotional support antibiotics. I'm going to use
happens every day in the hospital, and it's
terrible.
It's a pet peeve.
Richard, we want to get to you. Sujana actually watched. We had to talk to at NYU. Dr. Fauci gave a talk. He's been going to a lot of the medical centers and speaking about coronavirus. But we are now in the third known coronavirus pandemic. Can you talk about the other two and how they were actually curtailed really quick compared to what we're seeing now?
Yeah, that's absolutely correct. So it comes back to this family of coronaviruses we chatted about earlier. And there have been in the last, well, I guess since 2003, there have actually been 3 of these viruses, all belong to that same family, that have done this transition. They've been happily in some reservoir, probably bats. The first one was SARS-1, and that was a virus very, very similar to this particular virus, which, we're virologists, so unimaginatively we've called this one SARS-CoV-2 and the first one SARS-CoV. But that was a virus, again, happily in bats, found its way into, again, these live poultry markets in Southeast Asia. And if you're a virus, these markets, just kid in a candy store type stuff. So you're bringing all these different hosts together that are not normally in close confinement. These viruses can transmit around really easily, evolve a little bit. And again, that's what we think happened in 2003, 2004, when the first SARS virus came along, jumped over from these markets into people, very similar trajectory with this current pandemic. That virus spread again.
I want to say though, like when that happened in 2002, 2003, we saw a lot of Asian people wearing masks. We saw that was a concern that they were going to bring it over, but we didn't get quite the spread. Why not?
Yeah, so I think the answer is probably, and it's a probably because there's a lot of things with this we don't really know, but we think it's probably because of the spread. With the first SARS virus, it didn't seem to spread too much before symptoms started. Whereas obviously with this virus we have now, when we hear lots about this asymptomatic spread. So before you get symptoms, you can be infectious for others. The first SARS wasn't like that. So, if you think of those two environments, it's much easier to control the spread of that first one, because you tell people, if you get sick, stay home, and that's easy. But, how do if you tell people who don't feel sick at all to stay at home, everyone's at home. And so that's the difference between these two viruses. The first one, no transmission before symptoms, or very little. With this guy, lots of transmission before symptoms occur, and that that's just a whole different ballgame and much, much harder to contain. So that's the difference between the two. So SARS-1 spread a few thousand cases, but with these interventions, stop that in its tracks.
Yeah, I think you're right. That there were strong public health measures that were used, and really the number of cases were kept really low. Kimberly Connell is commenting that hydroxychloroquine was used to treat SARS. Do you have any opinion on that, Dr. Webby, and then maybe Dr. Shah?
Yeah, from my perspective, as I'm not a real doc, so maybe we'll flick that question to Dr. Hardy, but no, I'm not sure. I haven't seen any information on the success of that. I mean, from a virologic perspective, the use of some of these agents does make some sense, right? But in practice, a lot of these things that on paper looks like they should work, when they actually get used in people, they don't, and that's some of the problem. But I'll flick that one on to the real doc.
Yeah, sure. So the whole hydroxychloroquine thing started because genetically or in a lab setting, it made sense in vitro studies. However, a lot of things make sense in vitro lab settings, but they do not translate into clinical medicine. And so many studies have been done with hydroxychloroquine that I'm just fed up of talking about it, to be honest with you. So I do not think it works in patients in an actual clinical setting, because multiple retrospective, prospective, all kinds of studies have been done, and it does not work in vivo settings in the patients.
So, Adi, can I have you continue and just talk to us a little bit about prevention? So, people are
Sure.
really afraid. So we have two sets of people, right? We have people who are essentially become shut ins, who really don't go anywhere, and then we have those people who always wear a mask, always keep their distance, always wash their hands. We have this other group of people who, we read about that nurse's article where this patient was literally on their deathbed, death minutes with COVID, and was still claiming that it was not a real disease. So we have people not knowing whether they should wipe down their groceries, wipe down their mail. What is the right number of steps to do for prevention?
Sure. So this is a great question, and we live in a society, unfortunately, where it's either black or white, yes or no, right or wrong. But I do not think that's how real life works. The answer lies somewhere in the middle. Now, I do not agree with a lot of media reportage which is done on both sides. One of which says nothing is real. The other side says it's an apocalypse and you need to stay home and do nothing. The answer lies somewhere in the middle. So I'll tell you what I do personally. When I'm in a public setting, I wear a mask. If I'm going to a grocery store, before using the cart, I will use a hand sanitizer on my hand. And after I put the cart back and get my groceries, I would use hand sanitizer on my hand. When I was outside in the summer on a run, I would not wear a mask if I was alone and nobody else was around me. However, even outside, if you are in a setting like a market or something where there's a lot of people outside, even if it's outside, I would wear a mask. With regards to washing your mail or washing your groceries or washing your produce when you get it home, I do not think that is needed. If you just wash it like you would usually under running water before eating it or cooking it, I think that should be sufficient. So the answer lies somewhere in the middle. And I do not know what to say to people who do not believe in this. I think, unfortunately, that's just a sign of the times we live in, where everything is so polarized and partisan that if you believe in one thing, you belong to one camp, and if you don't, you belong to the other camp. I do not belong to any camp, and I think all of us in a global pandemic should adopt a more community feel to it rather than an individualistic feel to it. I get a lot of young people who tell me that, oh, I'm going to be fine if I get infected. Well, that is probably true, but if you transmit it to your mom or dad or grandmom or granddad, they could be in the ICU next week and literally be dying. So we need to adopt a more community feel to it. So I'm sorry if my answer confuses your audience and you, but the answer lies somewhere in the middle. We have to live, right? So I go to work, I do my groceries, but when I do, I'm smart. I wear a mask, I wash my hands, I do not touch my mouth, nose, or eyes. And if I'm going to a grocery store and I'm touching high touch point surfaces, then I make sure that whichever business I'm going to is cleaning that surface to prevent respiratory droplets, fomites from the previous person who has used it to affect me. And I use my hand sanitizer, and then after using that cart or high touch point, I use my hand sanitizer again. But there is a way that we can go on with our life with following basic precautions. The virus is very genetically smart in the sense that, as Richard mentioned, a lot of transmission is happening through mild or asymptomatic cases, but it is not hard to prevent yourself from getting it. In the hospital setting, we're also using eye shields or eye protection. That's important because that would be a setting in a hospital where you may be at a higher risk for exposure. But as I said, we just have to be smart, follow basic rules which have been laid out for the last several months, and I'm saying it again.
Thank you, Adi. And I think that that's so balanced. Those of you who are listening or watching, we are live on Facebook, YouTube, Twitter, and Scroll.in. And we're also carried on WBAI, which is 99.5 FM, and we're on Mondays from 2 to 3. And if you're watching and you think other people might be interested, and they can also watch the replays later, you can like and share and tag your friends. Richard, I want to talk to you about your work on influenza and its transmission, really in birds and animals. And we want to talk about how that has really translated to what you're doing with St. Jude and what that effect has on COVID-19.
Yeah, so I think we're all very familiar with the COVID-19 and some of the history behind it. But in many respects, COVID-19 is just one of many viruses that could come and cause some of these pandemics. And I think before COVID-19 came along, we were all thinking that probably influenza was the most likely virus that was going to come over and cause a pandemic. And so again, what we try and do, knowing that these things come along, they start their life as animal viruses, they evolve, they tweak, they then for whatever reason switch to become a human virus. There's been a lot of emphasis in trying to prepare for some of these events. So what we call pandemic preparedness. And, a lot of that goes back to trying to understand these viruses. So, what does it take for, a virus that one day is a bat virus, the next day is a human virus? What has to change in that virus? And the way we have to do that is so we go into some of these animal environments and we start looking at what viruses are circulating in there. So, in their normal state, what do these viruses look like? And then when we know that, then we can start to get a little bit more smarter when we see things happening like, well, hold on, here's a virus in a fish market in Wuhan, China that has properties we should be concerned about. And so, it gives us a little bit more, a little bit more prediction in terms of these pandemics, which at the moment we have none. And so, so again, if you want to looking at the slide now, there's not just a lot of similarities about how these viruses come out of the animal populations, and some of the some 70 to 80% of these emerging viruses actually come out of animals into humans. And again, I think some of the problems we have when they do this initially, as this slide shows, is initially a lot of these symptoms are pretty are the same regardless of which virus you have. So flu or COVID-19. A lot of the technology is similar, so it's very hard to know just looking at, say, symptoms what somebody has. And so again, the more we can learn about these, and I'm going around in circles here, but a little bit more, the more we can learn about these viruses, both in their natural environments and what happens when they get it over to humans, the better off we're going to be, both in terms of, detecting them early, getting a little bit of warning signal that they're coming, and then again, as that last slide shows, trying to, when they do come over, a little bit more sensitive ways to detect which is this and which is that.
Early on, the conversation was coronavirus isn't that bad. Flu is so much worse, and there's not like this whole uproar when you get the flu, stay home. Meanwhile, now everyone's like, "Oh, you're sick, stay home." Like I've gone to work with a fever in the past. I won't do it now, I promise. But I've done it.
So that segues really directly into not only distinguishing by symptoms, COVID and flu, but let's talk about testing, because I think people, especially around the holidays, are relying on getting rapid PCR testing or polymerase chain reaction, which is PCR, either rapid or 1 or 2 day turnaround testing, and saying, oh, well, now I'm done. We know there's a politician recently who tested positive one day and then sort of an equivocal or unknown result the next day, which kind of doesn't make sense. So Adi, can you talk to us a bit about what PCR testing does and tests? How accurate is it? And then I know you've really tried to work on how do we get a big throughput of people so we can get a lot of people tested at the same time.
Sure. Before that, I'd like to make 2 quick points with regards to prevention. I see a lot of jokes being made about people who don't believe in this pandemic or believe in basic precautions. And I don't think that's the right way to engage. I think we need to talk to those people and try and convince them rather than making fun of them. And second point is that though the symptoms of flu and COVID are quote unquote similar, I've seen and heard so many patients, it is not the symptoms are different. To give you an analogy, if you've ever taken care of an asthmatic in the emergency room, when they come to the ER, you give them a breathing treatment and they're not stable enough to go home, but they're not sick enough to go to the ICU or admitted. They need a few more breathing treatments. That's how COVID patients in with moderate risk factors sound 5, 6, 7 days after getting the infection. So a cough and shortness of breath for flu is different than a cough and shortness of breath for COVID. And coming to your question about PCR testing, polymerase chain reaction essentially tests whatever sample goes to the lab to look for genetic elements of the virus, and then they amplify whatever genetic element is found and see if those genetic elements, after a particular threshold of amplification, meets any genetic similarities to COVID-19. So that is the PCR test. The antibody test, we don't know what to make of it right now. Essentially tests for antibodies in somebody who may or may not have been exposed to COVID. We don't know how long, what are the titers which confer quote unquote immunity. So more studies are needed for that. Rapid antigen testing is looking for just basic antigens of the virus or infection in your system, which is not as good as the PCR testing. A lot of non-nasopharyngeal swab-based testing or a saliva-based testing has been coming out. Minnesota is offering a free saliva test to anybody who wants to get it, a mail-in system. So that is another avenue that we can get if we wanted to expand testing. And this paper that you pulled up on your screen, this was a great monumental effort, which essentially signifies the collaboration that exists at Mayo Clinic. 7 days after seeing our first case in Minnesota, we had a drive-through testing site which was capable of testing hundreds of samples every day. This was in the middle of March. Man, that sounds years back. And that's when we started doing the drive-through testing, and we were capable of testing 500 to 1,000 samples every day in a town of about 100,000 people. So that was huge. Now we are switching this drive-through testing to an indoor appointment-based testing because of the cold that is outside. And even now, we are capable of running several thousand samples every day in our lab. Our colleagues in lab medicine have been instrumental in this because they came up with the diagnostic test, the PCR test, and in-house test within a couple of weeks of the first case being seen in our state. So testing is very important, and that is why I think we saw initial successes in Minnesota to keep the numbers manageable. And now just, I don't know if it's COVID fatigue or people just not following the rules and regulations, we are seeing more cases, but thankfully our lab and hospital is capable of testing all those things.
So we have a question from one of our viewers from sunny Southern California, Dr. Nina Yashbi. How is the weather affecting the virus? And I'm going to ask you, Adi, and then maybe we'll also ask Richard to talk to us about seasonal variations in influenza.
Sure. So though everybody said when this started, oh, it will go away when the summer comes or the weather gets warmer. While that is true for some viruses, we did not know how this virus was going to respond. And true to its character, it did not go away in the summer. In the winter, our concern was co-infection with other respiratory viruses like your flu, RSV, and other respiratory viruses. Thankfully, because of all the masking and the precautions and the hand washing and the distancing and disinfection of surfaces, we have seen lesser flu than usual, which is a welcome positive that we need. However, flu season has still not kicked in. So to combat that, now we will be offering a combined respiratory pathogen panel type sample, which also has included COVID in it along with flu. So we just need one swab and one transport media to test for all these viruses. So I hope other centers are doing similar innovative techniques to preserve transport media and be more judicious with our testing reserves that we have. But to long story short, we are bracing ourselves for the flu season, and so far we've been able to manage it.
Richard, let's talk a little bit about what's been happening to the flu season. since March, both in the northern and the southern hemisphere.
Yeah, so this is, again, if there's a silver lining to a pandemic, I think this would be it. As Dr. Adi just said, what's been seen around the globe, and again, when we in the northern hemisphere go into our winter season, we often look to sort of my home hemisphere, which is the southern hemisphere, to see what's gone on down there. And so if we go down there and take a look at what their winter's been like, there has really been none of these other respiratory viruses circulating. So flu activity, when COVID-19 came along, even in countries where there was some flu activity at the time, flu went away, RSV went away, adenoviruses went away. And I think yes, there certainly is this impact of social distancing, the mask wearing, which works really well against COVID, and it seems to work probably even better against other viruses. Yeah, and the slide you've got up actually now is one. So we meet as a WHO network, we meet a couple of times a year to make these recommendations for what strains should go in the flu vaccine. This actually shows the real data they talked about. So if you look at those bars that go along, the higher the bars, the brown and greens, just the more viruses. So this is looking just for flu, the northern and southern hemisphere. The dotted lines you see going up and down is essentially when COVID-19 came along. And if you look downstream of that, flu went away. And it's maintained that. So yes, it's a social distancing. It's also the mask wearing. But I think even interestingly, if you look at some countries, even in South America, that didn't do such a good job of controlling COVID-19, they have actually not seen much flu activity either. So I think it's a little bit of both. These social distancing, mask wearing work remarkably well for flu, probably better than people thought. But I think also this SARS-CoV-2 virus is muscling out these other viruses a little bit as well.
Yeah, so we put up this graphic to show there are different types of influenza viruses, and really much of how it affects us is due to our susceptibility of the host, which is the person or the animal who gets the disease. As we're moving along, because you guys are amazing and we only have about 14 minutes left, let's talk a little bit about treatments, and then let's talk about vaccinations, because that's really the big story right now. So we have several treatments that have either approval or emergency use authorization, EUA approval by the FDA, dexamethasone, which reduces mortality for really sick people in a significant in less than a third or a fifth, but that's a significant percentage. Remdesivir was approved by the FDA on October 22nd, but in fact, the WHO this week advised against using it, so the data is still out for that. And then we have a couple of things that just got emergency use authorization, baricitinib, if given with remdesivir, and 2 antibody treatments, the Eli Lilly regimen and the Regeneron regimen. But let's go from there to vaccines, because it seems like there's a little bit of magical thinking that suddenly the vaccine's going to come and it's going to fix us all.
Yeah, let's just talk about those treatments and Adi, just what you think about them. Can you pop up the other slide again, and then kind of you run through it?
Yes, sure. So COVID therapeutics and EUAs have, I think I made a meme about it recently. They're just like every day something else is coming on. I've done 3 weeks of COVID, and each week has had its own new therapy that has come out. Now, from my standpoint, the strongest evidence is to use dexamethasone in certain patients, especially those who are sick or have oxygen saturation less than 94%. Your slide says 10 days, but it can be anywhere between 5 to 10 days, or it can also be stopped when patients get off oxygen or get off the ventilator. And dexamethasone works in ARDS or works in inflammation, and that has been known since the beginning of time. However, we have proved that with studies. Yep.
Just tell our audience what ARDS means.
Sure. So ARDS means acute respiratory distress syndrome. Essentially, when your lung goes into a self-harming cycle of inflammation, and dexamethasone or other steroids or anti-inflammation medications would stop that. So we know that that works. Remdesivir showed decrease in hospitalization or length of stay in studies that were done in the U.S., and that led to initial EUA, and now it has been FDA approved as well. And the key of remdesivir or dexamethasone is that remdesivir is an antiviral medication, so it has to be used early in the course of disease. Once the cascade of inflammation starts, it might not be as useful, which might be around, say, day 13, 14, after which you need steroids, which are suppressing the immune system so that you do not go into ARDS. Now, the monoclonal antibodies, again, have been shown to, in very, very small studies, have been shown to be effective in patients with high risk of disease. This might include patients with obesity, high blood pressure, diabetes, kidney disease, the elderly, the immunocompromised, in combination with remdesivir. And that EUA, or emergency use authorization, was just passed. So we are setting up infusion centers so that we could give that to some patients. Now, the evidence of this is so ever changing and so rapidly progressing that this might change 5 minutes after we talk. So that is the evidence that exists right now. But I think dexamethasone has the strongest evidence of utility.
And let's pop right into the vaccines then.
Mm-hmm.
So there have been a bunch in trials. There are like 26 or something that are in trials, but there's 4 that are kind of close to that being available, right?
Sure. Yes. And 2 of them are already going to be available very soon: the Pfizer vaccine and the Moderna vaccine, which are essentially mRNA vaccines, which essentially means that it contains material from the virus that causes COVID-19, and it gives our cells instructions to make a harmless protein that is unique to the virus. And once our cells make that protein, they destroy the genetic material in the vaccine, and then our bodies recognize that that protein essentially should not be there, and it builds T lymphocytes and B lymphocytes to fight it off, and then it provides protection moving in the future as well. The Pfizer vaccine had about 40,000 volunteers, I want to say, and it showed about 90 to 95% effectiveness, which essentially means that in about 162 COVID cases that happened, 170 COVID cases that happened, about 162 happened in the placebo group, or those that did not receive the vaccine, and only 8 happened in those who got the vaccine. And of the 10 severe cases that happened, only 1 of the severe cases happened in patients who got the vaccine, the Pfizer vaccine, which essentially shows that not only does it prevent infections, it also prevents severe or serious life-threatening infections. The Moderna vaccine had 30,000 volunteers, and they only saw 11 severe cases. And all the 11 severe cases happened in the placebo group. And with regards to side effects, 2 to 4% of patients had some basic side effects like fatigue or tiredness, but they did not see any significant drastic side effects, which is excellent. And people tell me, oh, these vaccines have been rolled out very fast. Does that mean they will work? But they have still followed all the right steps of vaccination. Now, their sample sizes may be small because we don't have time, as opposed to other vaccines, but 40,000, 30,000 is still a robust number. And I've looked at the studies myself, and I've heard Dr. Fauci speak too. And if he says it's legit, I think it's legit. So, and 90 to 95% effectiveness, that's pretty great.
So there's one thing, and maybe Richard, you can speak about this too, that people were concerned that there have not been very successful messenger RNA vaccines before. Have you heard about that?
Yeah, so that's, it's a remarkable amount of activity that's gone on the vaccine front for this virus. The amount of approaches, the amount of resources, and just people power that's gone into this is amazing. And so what's gone on is some of the new technologies that have been in development for a number of years, but this has really pushed them to the forefront. So if you look at that list that we had up before, those 4 vaccines that are coming along. 2 of them are mRNA. There's no licensed vaccine that's used that platform before, but they have been in clinical development for things like flu over the past decade. So it's not like we're starting from nothing. There is this wealth of information on them. The other, the adenovirus, or the viral vectored vaccine that were also on that slide, again, similar types of thing. These have been in the research settings for a decade or more, and it's really this push, this global public health emergency that's really pushed them in the clinic faster than maybe they would have before. So yes, they are new technologies in terms of mass vaccination, but they're not things that we dreamt up yesterday and are going to put into people tomorrow. That's not the case at all.
You know, when I was reading about how these vaccines were developed so quickly, I was really impressed by the knowledge sharing. As you said, we didn't start at zero. It's sort of like a relay race where the first 2 or 3 runners had already been running. And so it was literally a Microsoft Word document that was shared across country lines between researchers that almost made the mRNA be able to be a plug and play so that we could get to the, as Adi says, very important and very rigorous work of human trials. So if you guys have not read about this to our audience, the story behind how this happens so quickly and so efficiently will warm the cockles of your heart. So let's talk about vaccines work, which is great in these clinical trials, but they actually only work if you receive one. So can we talk about who's going to get these vaccines and in what way is this going to be rolled out? And London Robinson, who's a medical student who was on one of our shows, she plans to go into rheumatology. She asked a question about are we going to see rural communities included, or is this going to be yet another way that we somehow ignore vast swaths of our population? So maybe, Adi, I can talk to you about how are we going to determine who gets the vaccine first, second, third, and fourth? Is it just going to be NBA players like the testing, or is it going to be somebody else?
The NBA players. The NBA and MLB did such a great job at widespread testing. I sometimes wonder why we couldn't do it. Anyways, that besides the point. With regards to vaccines, the healthcare workers or frontline essential workers will get it first, and that just does not include healthcare workers. This might be the person who bags your groceries or who makes your food in your cafeteria in the hospital. So these are also included in essential workers, your postal workers, people who go door-to-door deliveries, etc. Those will be the first to get this vaccine. We might be getting in healthcare workers later next month or early January. After this, the next step would be to be giving it to vulnerable people. That might mean the elderly or the immunocompromised. And then I believe by, say, April, May, or June, everybody should be starting to get it. And with regards to questions about rural access, that's an excellent question. Rural communities have 2 things right now: lack of healthcare, adequate healthcare, and large spreads or outbreaks of these super spreader type events there. So I think, I'm not a policymaker, but whoever is making the policy, I'm sure they would have included rural communities in this as well. There's no favoritism that comes of big cities versus rural communities. Everybody has to get vaccines, and they will work only if you get herd immunity through vaccination, not through infection.
Right. Let's switch gears just real quick. We only have 3 minutes left, and we want to show some that you guys are quite accomplished, and not just in like Adi, not just you doing your ID stuff. So first, Richard, you won a great award. We want to pop up a slide. This is a 2010 Special Award, just so you guys know that we only have really, really awesome experts on it. But this is all for H1N1 influenza, which is the predominant strain of influenza research. And you look exactly the same, man. It looks great, Richard.
Thank you.
And Adi, you have this great story that Suju found that
oh no, yes.
Tell us about this.
That's a bit embarrassing, but yeah, this was in 2018. I was coming back from India, so I had a flight from Mumbai to London and London to Minneapolis. And after we took off from London, this gentleman they called the whole dreaded "Is there a doctor on board" thing, and I went ahead, and this guy had an eye patch on, and as soon as I took his eye patch, he had frank bleeding from it, and their blood pressure was systolics were higher 200s. So we just asked somebody to give us lisinopril from in the flight. We gave that to him. I kind of fashioned an eye patch with some ice packs and one of those sleeping masks to keep it snugly fit. And then we had an emergency landing in Ireland where they took care of this gentleman, and then turns out they came to Mayo for care, which was pretty awesome. And yeah, as a medicine doctor, the three things that I get scared of dealing with is ears, nose, and throat, ENT. So however, I had trained in a hospital which had a very busy emergency room in Chicago, south side of Chicago, and I'd seen a lot of trauma in those areas. So thankfully, my training came in handy. And yeah, things conspired that me, a nurse, and an EMT were on board, and things just worked out so well for that gentleman.
And that worked out great. Well, you guys, we love the show. Thank you so much for joining us, to both of you. Again, you can, if you're watching and you caught only the end, you can rewatch it. We are on LinkedIn, YouTube, Twitter, Facebook, and we will be played on WBAI radio on Monday from 2 to 3 p.m. Eastern Time.
And we want to thank our incredible production team. They keep us on target. They keep us on track. We want to thank our producers, Rose Horowitz, Vandana Menon, Julia Weeks. Our video highlights are posted for the next week on Twitter and Insta by Keval Ramanathan, our design director, Shristi Hebar, and our beautiful voiceover sounds by Nicole Lewis. So thank you guys so much for it. We want to thank our guests, Dr. Richard Webby, Dr. Aditya Shah, for spending the time with us, and wish you all a happy and healthy and safe Thanksgiving. Stay home, wear a mask, wash your hands. Let's stay safe.
Right. And so we're going to take next Sunday off, and but we'll be back on December 6th, and we look forward to having you all join us.
Thank you.
Thank you.